Good morning and welcome everyone. Thank you for taking the time today to attend this webinar titled HL7 FHIR and Data Interoperability. Today is Tuesday, November 2nd, 2021, and I am Chris Hoffman. I'm a business data analyst with the NEMSIS Technical Assistance Center. I have the privilege of introducing Andrea Fourquet, who will be our host for the training today. She will be providing a high-level overview of HL7's FHIR standard and its impact on healthcare data exchange. And she will also explore the technological, operational, and regulatory factors driving the use of FHIR and how it will impact the EMS community. This meeting is being recorded so that you can review the information at a later time. And we do also view these trainings as a conversation. So if you do have a question, please feel free to put it into the chat or to unmute yourself and ask a question. With that, I'd like to go ahead and turn over the time to Andrea. Go ahead and take it away.
Thank you very much. We'll start by sharing my screen. I believe. All right. Hello, everyone. I am Andrea Fourquet, and I'm here to present some FHIR for you. This is an overview, and I would like to precursor that. I would like to say that FHIR is very complex and cannot be contained into one information session or training session. So if you have any additional need for additional data or presentations, just let me know at the end. So I'm here with my two coworkers, John Murphy and Adam Baser, who will be participating in this presentation as well. And so we'll start with what FHIR is. FHIR in itself is an acronym. It stands for Fast Healthcare Information Resource. And this is a standard that was developed by HL7 to do fast healthcare information exchange. What we'll be focusing on is FHIR version 4. The version is important to note because there are several other versions prior to this one. And
excuse me, Andrea?
Yes.
Excuse me, it's Eric. How are you? Hey, your microphone is sounding awful like echoey or tinny.
All right, let me just turn my headphone on. I hope this is better for everyone.
No, it's still a little like scratchy. Keep talking.
Awesome. All right. So as I was saying, the version, if you are looking into implementation guides or resources, you should keep an eye out for what the versioning is, because that can change. The structure of some of the resources can change between versions, and there might be some further interoperability challenges that come with different versions of them. So this FHIR standard is composed of resources that are used to break up the healthcare data, and within those structures are defining how the data will be structured and exchanged. These resources start as a very generic baseline and are meant to be able to fit a wide range of use cases. So they tend to not have any value set bindings, any resource bindings. They're very open for further profiling or implementation that may just want to use that generic resource. It's structured this way because it's so that they can exchange resources instead of the full CDA documents, which can be very burdensome. And it's commonly used for mobile apps, cloud communications, EHR, data sharing, server communication, and even for exchanging CDA or CCDA documents itself. So we're looking into how it works. So each FHIR resource, like I said, is a piece of healthcare information. So they're broken up into something like patients, observations, clinical impressions, adverse events, medication statements, conditions, and obviously it's not limited to those, as this whole group right here are the full index of the resources that are available and structured in FHIR. An example of that resource would be like the procedure resource, and these will contain a structure to support important attributes like time, performer, body site, and outcome for the procedure that you are referencing or structuring. Again, these are meant to be used as building blocks. So you can say, I'd like the patient and I'd like their procedures, and all I want to know is what procedures this patient had. You can ask just for those two resources, or you can ask for a bundle or composition of those resources. So you can say, I'd like patient, I'd like 5 or 6 different resources, and these are what they are in an implementation guide, and that's what those implementation guides are defining. So these resources are used almost as templates, so that if they don't contain everything that you have, they can be extended and reused, and that extension can be reused as well, and then even constrained. So when you're constraining it, you can constrain it down to value sets or fixed code values. So you're saying, if you have your patient and your procedure, well, I only want, for this instance, for NEMSIS, I only want the procedure codes defined in this NEMSIS value set. And so when you're structuring that element, then you are pulling those values from a specific value set. And then those bindings can be strong, which is required, preferred, which is lighter, or an example, so you can interchange them. And this also includes constraining the data elements, saying, I need to have the patient identifier. You can't give me a patient without an identifier in this structure, So, and we'll see an example of this this template on another slide. When you do need to constrain, extend one of these resources, it's called a structure definition. So if you would like to do that on your own or in an implementation guide, you'll be using structure definitions to call out what you are constraining and what the value sets are you're binding to it. And so that structure definition will become your structure definition resource. And that itself might be able to be reused depending on how strictly you constrained it. And these are often used in profiles. So even if it's a structure definition defined in a different profile, in a different implementation guide, you can still use it in your own. You just have to say, we're going to be using this structure definition, and you have the link there. A lot of the times, because they're reusable, it's very much recommended that you search for a structure definition that already exists with an extension or a constraint before making your own, because it makes it a little bit easier for these resources to be reused. But again, it's not discouraged to be creating new structure definitions. And if you want a more technically in-depth description of this, this is available at this link here. So here's an example of what the patient resource structure or any resource structure will look like in the FHIR implementation guide. This is all online on FHIR.org. So you can see that we have patient, which is the resource that we're talking about. And so you can see each of the elements that are defined for patient that is a part of these of this resource. Because it's what we call like a template resource, all the cardinalities are open. So you can have none of this element or many of these elements. One thing to note is that you can constrain an element, but you cannot expand on it. So if you have a patient active Boolean here, you can't have more than one Boolean defined in a new structure definition. So if you're creating your own structure definition, you're saying you would do something like constrain a cardinality. So you'd say for the patient name, I would like at least one name or two names if that's what you need. You would say, I would like at least one. So this is, if you change this cardinality, then you are requiring that element. Whereas this, when it's open, it stays optional or required if known if you're defining it at that level in a implementation guide. And if there is something that needs to be extended, you can do an extension or a slice in any of these to achieve your goal in your structure definition. So we have two forms of how FHIR is used to send multiple resources. You have a bundle and you have a composition. A bundle is just a bundle of resources that you would like. So an example of this would be, give me the patient, their medications, and their procedures, and that's all I want. It's not restricted to any number of resources that you can ask in a bundle, but you can have a bundle made up of this. A composition is a little bit different because a composition is defining almost a FHIR document. Well, not almost, basically a FHIR document. So it'll have entries and sections with the resources that you're looking for. So if you were to say, I would like to look at the International Patient Summary composition, you'll see that they have section for advanced directives and the section for medications and section for immunization. These are how you separate these resources into what would look more like a document. And this is what you call a FHIR document. This is a large number of resources with more strict definition of what those elements mean in sections. So you'll see, well, you'll see an equal amount of bundle and composition, but if you were trying to do something like send over a document, that would be a FHIR document. I suggest that you do look at the International Patient Summary composition page because I think that will give you a good sense of how that's being accomplished and how it utilizes a large number of resources to create this summary document. So going on, we're looking at some FHIR-based profiles in IHE. These ones are in IHE just because these are the ones that I feel are most relevant to this group. But again, these FHIR is utilized by IHE as well as HL7 in profiles and implementation guides. And these are ready to be tested at an IHE North American Connectathon if you would like to. So we have our EMS specific ones, which are paramedicine care summary. This is a FHIR document composition. And this defines two different documents. One is the clinical subset of the document. So it would be the document you would share with an ED when you're sending a patient in. And this uses a send transaction. And then we have the complete report, which is what you would end up with at the end of the completion of the documentation. So this includes dispatch information, protocol information, the narrative piece, those pieces that are not necessarily usable for the ED, but are usable for things like quality measures and outcomes reporting. The referral for interfacility patient transport is used for, as it says, interfacility patient transport. So this is getting patient information out of the hospital when you are transferring a patient. This is the information you want to know about them before you transfer them, with the ability to query the hospital for the patient's information. Then you have the quality outcomes reporting for EMS. And this is the reporting mechanism with FHIR. So there are two different transactions that you can use for this. You can use a query and you can use a send. You can query for additional information that your report may not have, and you can send the composition of the resources for that are identified for e-outcomes, measure reporting, trauma registry reporting, et cetera. It's more open so that it's flexible to use both EMS and hospital data to report to a registry or report back to the EMS company that had, or organization that had transported the patient in. Then we have our transaction specific profiles. So these are the transactions that you would be testing for interoperability. And these are the transactions that follow FHIR. And so, for example, the paramedicine care summary uses the MHD, mobile access to healthcare health documents transaction in the profile. So these are the building blocks that you can use for additional profiles or additional interoperability transactions. One thing that I think that would be interesting for everyone to take a look at is the white paper that IHE has put out for document sharing and HIE exchange, HIE, because this is what, this defines all of the transactions that you would need to connect to health information exchange. And I think it's a very useful document to really look at how many of those transactions there are and how to do it successfully. So I think I highly recommend looking through that white paper as well if you have goals with connecting to an HIE. So based off of what I gave you guys there, this is kind of like a workflow of how this information can be exchanged. I have included a different profile here that was not mentioned before because it's not EMS specific, and I would almost call it optional for your uses or recommendation for use. So this is kind of like, this is a workflow that I had put together for a few of the profiles that I put together. So if you're arriving to the patient, you are able to use this implementation guide defined by HL7 and IHE as a collaborative item to query for the patient information on the scene through an HIE. And it is a patient summary, so it may not include something like their vitals, though it does have a section for this. Then you have the paramedicine care summary that you would send to the hospital when you arrive or prior to arrival. And then after the patient goes through their hospital encounter, this is where it gets kind of messy because CORE has a few options of what can happen. The hospital can send the report to an HIE, or they can send it to an EMS, the EMS organization, or both. They can query the EMS organization if they were not able to consume the complete report from the paramedicine care summary for that additional information that would be found in that report. And then the EMS organization can also query the hospital as well for the additional information, or the HIE where the hospital will send the information. And then also the EMS can send a measure report to an HIE containing the information for trauma registry measures or heart attack cardiac measures. The second workflow that I have is an interfacility patient interfacility transport workflow utilizing the new but a new option that was put into the 360X profile that is found in IHE. And this is where a hospital will request a transfer from their organization to another facility. They will send initial patient information and also a CDA document with patient summary defined by RIPT, and then the ambulance crew would also be able to query the hospital with this referral for inter-facility patient transport query to get additional or missing information. And then we repeat the paramedicine care summary and core transactions from the receiving facility. So these profiles and transactions can be tested at HL7 and IHE connectathons. The HL7 testing is going to be testing standards, testing against the standard to kind of see what improves it if something doesn't work. It's for the standard alone. The IHE connectathons are for product testing, interoperability. So, and there's an opportunity to go to both. You don't have to pick one over the other. It's actually highly recommended that you take the path of both of them, just so you can get that repeated experience of testing the standard and then up to validation and production. And so you're able to do this with other vendors. So this would put you at the table with other industry vendors. So, EHRs, health information exchange, public health, et cetera. And that's where you would gather and kind of implement and test the interoperability of these standards. What I would look for is feedback if you weren't able to properly or successfully exchange information, if that was something of the standard that wasn't spelled out correctly or flawed, then that's where you would provide comment back. And I should also mention that these profiles that I had showed you are open for comment at all times right now. It's in trial implementation, which means that we expect comment to come in, and because IHE is on a continuous cycle, that means that you can put forward a comment for a change at any point. So, and I believe you were given these documents a few days ago and again this morning to review, and I look forward to hearing your opinions on those documents, what I can do to improve it. So that's one of the outcomes of a connectathon as well. So we are, so IHE itself is looking forward to getting an involvement in the 2020 North American Connectathon. And we're trying to create a path for EMS here. So we're trying to, and not just EMS, but here we're focusing on this today. We're trying to guide everyone through the stages of going through Connectathon and adopting standards. And so we're trying to put together a bi-monthly 2-day digital events to kind of coach you through the process, give you an ability to ask questions or troubleshoot anything that might be happening with and help you progress it. And so we also are looking to have free attendance to educational sessions and workshops. And while the testing services are still available for purchase. And continuing from there, we are looking to gauge from the group any questions. We have some questions for you guys, actually. I think that's the better way to put it. We have questions for what we can do about having some involvement with that, as well as any challenges that might have with implementing such FHIR standards or implementing the IHE standards as well. And I am going to actually pass the presentation off to my coworker, Adam Baser, to take on this question for him.
Thanks, Andrea. I really appreciate it. And if we could just advance to the next slide. So to just frame this discussion against what Andrea was just sharing about our Path to Production series, we're really trying to focus our activities in 2022 by going directly to each healthcare stakeholder and try to see where IHE can be most supportive within their individual priorities. And so taking more of a targeted approach where in past years we may have taken a more general approach in our focus and our themes. Our goal this year is to meet people where they are and help them along that path to production. So hoping, and Andrea, if you can maybe just scroll through these slides, just the question slides, so everyone can kind of have a preview of where we're hoping to take a bit of this discussion. And then we really look forward to the thoughts from the group, and we can kind of go through these questions one by one. Wonderful. And Andrea, I'm hoping that maybe we could start our conversation. Now, if you can go up one to priority use cases, because I think that might be a helpful. There we go. I think that might be a helpful launching point for the conversation. But to frame what we're seeking, we'd like to understand what are those use cases, what are those priorities within the EMS community that you are focused on in 2022, so that we can then be able to speak to the resources that IHE USA have to help support that. And so I'd open the discussion up to the group here. From your perspective, what are the priority use cases that the EMS community is focused on in 2022 and is seeking to make actionable progress around?
Don't everybody speak up at once.
Yeah, you can just speak at will at this point. Or if you have any initial questions that you want to ask to contextualize this question as well, you're welcome to.
Hi, this is Jonathan Fight. No one else is going to say anything. I'm happy to. I'm from Beyond Lucid Technologies. There are certainly a number of emerging and important use cases as pertain to interoperability. Got a number of hospital systems that seem to have woken up to the idea of sharing data in real time using consumable formats. We've got emerging standards operating in parallel, certainly as Andrea knows, things like Pulsed, and also now a focus on pediatrics as well. There are certainly our organization has been thrilled to be involved in moving those forward, and certainly a renewed interest in syndromic surveillance, provider wellness, basically understanding who is being exposed to what in real time and being able to identify who's at risk. That certainly ties into the importance of closing the gap between what hospitals and public health are aware of versus what EMS and FHIR are aware of. recently came up in the context of PDMPs for substance abuse as well. So the idea that there is at present a knowledge gap between what happens in a pre-hospital environment and a post-hospital environment versus what's happening in an in-hospital environment, and how the in-hospital environment gets communicated elsewhere in the public health system, but is missing details from the other areas. Let's just say, since this is a public forum, those processes those gaps are in the process of being closed, and we're certainly thrilled to be involved in them. Thank you.
And thank you for that comment. Do some of the areas that Jonathan was referring to as it relates to syndromic surveillance or pediatrics, implementing emerging standards in parallel and closing that knowledge gap in between pre-post and in-hospital environments. Do those speak to others on the call as shared priorities? Are there other areas that that you would want to inform IHE about in a way that we can help support? And why don't we maybe build off of Jonathan's comment around syndromic surveillance? Is that a priority that others are seeing emerge from the pandemic? Are there ancillary priorities or complementary priorities around that others are dealing with?
I mean, I guess I find myself wondering how it could not be. I don't know why everybody's being so quiet here, but clearly there is a need to know where sparks of infection are occurring. I can tell you, speaking for Beyond Lucid Technologies, we were thrilled to have a peer-reviewed article published a couple months ago. It was in the springtime of this year, and it looked in what we think was a pretty interesting fashion, and so did the folks who published it, apparently. We looked at 4 different EPCR systems, ours, Zoll, Stryker, and ESO. And we did essentially a cross-sectional review over 12 states and looked at the relative impact of essentially media representations of COVID concern, I guess is the best way to describe it simply. We looked at whether the population in the areas that we studied, those 12 states, were truly ignoring cautions and kind of just being lax about protecting themselves from COVID. And what we found was actually the opposite. The data suggested that folks were actually on a hair trigger and they were being more cautious. They were more concerned. They were over triaging themselves. So I think that provided a powerful example of how syndromic surveillance can hope to cut through the reality of sometimes bumper sticker messages and other media representations to say, what do the data actually show as far as what is happening in the healthcare environment? Obviously, in this case, there's some bias insofar as the folks who use ambulance services, but in general, is that we had enough sample to draw some conclusions. So I think syndromic surveillance is a reality. There's certainly a lot of people who don't understand how it works. They don't, certainly among the public, and there's a lot of probably fear around the word surveillance. But the same principles that are being applied to COVID-19 can absolutely be applied to other forms of infectious disease and substance use disorders, chronic disease, what I refer to as the chronically acute, which is sort of people who continually make themselves sick by putting things in their bodies that shouldn't be there. And I'm going to be giving a presentation next month, or I guess this month, next week, in fact, in Kansas City on the use of syndromic surveillance and similar types of data to identify and hopefully intervene on behalf of responders who may suffer from PTSD, but not speak forward on it. Certainly, I mean, there are lots of ways to slice that conversation. Again, I don't know why everybody's being so quiet, but certainly syndromic surveillance in a variety of forms is an emergent reality from the last 18 months. And in my view, I'd say it's about time. Absolutely happy to send you that article.
So I think another
Jonathan. Oh yeah, go ahead.
No, Adam, you go ahead. I'll follow.
I was going to suggest, Jonathan, if you could share that article in the chat window. That way, everyone will have access to it. And we do really appreciate you sharing your perspective and where you're seeing the priorities emerging. And yeah, Andrea, thank you for adding context.
I think another piece of this question is also based off of the workflow pieces that I showed previously in this slide in this presentation, where we talked about the transport to the patient in the facility, to the hospital, and then interfacility patient transport. During those workflows, did you feel that there was something missing in those? Do you feel that there were, other than the general workflow of the actual EMT interacting with the software, because I think that's a little bit out of scope of what we're discussing. But I think another way to shape this is that, do you feel that in those two workflows, there was anything missing that you would like to see, or wish that was there?
Andrea, maybe if you can go back to that first workflow so we can have the visual.
Hey, this is David Balcom. I'm with Alpine Data Lab and snapdata.io. I have a question for anyone who is close to the technicians and paramedics on the front lines. In terms of the inter-facility transfers, a lot of times patients are having spent thousands of hours in the clinical environment, watching patients wait for a service to pick them up and transfer them to another facility, or watch a patient in a hallway waiting for a bed to open in that same queue, because that patient hasn't been able to be transferred. Is there anyone that's closer toward the front lines or toward the administration on the front lines who might have any information or insight into what some of the slowdowns are, or what information that the organization, whether it's Gold Cross or Southwest Ambulance or Ambulance Company X or Ambulance Company Y, whichever they are, what are the things that they see as barriers to their workflow and getting things done quicker? What would improve the pace of that transfer so that the entire queue in a busy hospital could be freed up and obviously cost less in the end? That's my question.
Well, I can give you some context. Is that I'm the main author of the of these EMS profiles, and the first one that was done was the referral for interfacility patient transport, because I was an EMT at the time in Boston, working for Fallon Ambulance Company, and the majority of the calls that I was on were interfacility patient transports, specifically out of like Mass General. And one of the biggest pieces that one of the biggest hangups of getting someone out of the hospital was being able to get the patient information in the first place So they would print out a stack of patient information or hand you the chart, and you had to hand type everything into the EPCR. And then second, you couldn't leave without a signature from a nurse to sign off on the it was a previous version of NEMSIS, but it was the certificate of medical necessity. I think it's definitely named something different now, but at the time, those were the ones that were the biggest pieces, right? That was the piece where you'd show up, you'd spend 20 to 30 minutes typing in the patient's information, and then you have to wait another 15 or 20 minutes to get that nurse's signature on that that medical necessity form. So that's kind of essentially where it inspired the referral document in the query piece right here, was to be able to get that patient information into the system instead of hand typing it. And a piece of that query, and even a piece of the 360X referral, is that you have that the certificate of medical necessity, you have that signature, and you have that reason for transport, essentially, reason why they had to be transported by an ambulance instead of on their own, listed. And so I can say that those were my personal experiences there. And then also when you brought someone to an ED, one of the hangups was the discussion of the handoff. So reiterating everything that you typed into, or at least a good chunk of the information that you've already typed into the EPCR to the receiving facility. And that's what we were trying to accomplish here. But I welcome others to speak up as well. I just felt that the context was, that was the context of what this workflow is for.
Oh, that's really helpful. That's kind of what I'm driving at, is what are some of the factors that on the front lines are the barriers, and what are the priority issues for the frontline staff, so that we can develop the priority technology, which you've already started doing, to address that issue. So that's really helpful and understandable.
Well, if I can chime in real quick, I mean, again, this is Jonathan Fourquet, Beyond Lucid Technologies. I would throw out that there is an important consideration, often not thought about, but needs to be, that in order to facilitate the useful handoff of data the way Andrea described, you need people entering it in a timely fashion. That is a challenge when either you have agencies utilizing a web-based application in an area where they don't have the network connectivity, or they're waiting until they get back to the station for a variety of reasons. The reasons can be debated at another time, but there is a kink in the workflow whereby if you're hoping that information will be available to avoid replication, we need to bring the utilization of the documentation system closer to the handoff period. Again, there are many smart minds on here who I'm sure will have lots of opinions, or whether they say it or not, on how to make that happen. But the missing link in the workflow is, in general, the use of the documentation system in real time. Obviously, some of us have taken that bull on with two horns and we are shaking it. But there are certainly large-scale deployments out there where agencies have no expectation that they are going to utilize their technology in the field at all. They are going to wait until they get back to wherever they left from, and when they have the first moment of downtime, which could be well after the patient has already left the emergency department, or sometimes even the hospital itself, before that report gets there. That is a challenge that this industry has not taken on, in my opinion, with sufficient rigor, but it is absolutely essential to moving this interoperability bit forward in a useful fashion.
Yeah, I think one way to put it is that there's a limit on the capabilities of the providers, the EMS providers, and their time and the time that takes to input information into the EPCR. So if you were to do something like import the patient summary into the piece, then you get some of the patient history, but you're not going to get very easily the medications administered or procedures done, like the procedures performed pieces of the workflow that happens in the truck. And that is a barrier of workflow,
Well,
which is, yeah, it is a complicated one for sure.
let me pause you there, because what you just crossed into the area of design, Andrea. That's not a technology issue anymore. There are EPCRs represented on this call. Again, I'm not going to advertise mine, but there are EPCRs represented on this call that have addressed that very issue using design. So there are ways of making it easier to capture medications, procedures, other information about what has been performed seconds earlier. Using software design principles is not a technology barrier, and that is a pretty important misconception that such things can't be done. The fact that they are not done everywhere does not mean they can't be done, and they aren't being done in some places. Sorry, I just want to make sure we put a pin in that, because modifying that workflow using UX design is absolutely something that can and is being done right now. That facilitates real-time handoff, even data that arrives at the ED prior to the ambulance, and that's been done in states ranging from Colorado to New England. It is absolutely being done right now. So let's make sure that we draw a bright line between the historical ways that things have been done and again, user design principles that facilitate upfront documentation and real-time transfer of data so that it can be useful in the hands of the ED even prior to the ambulance arrival. Totally being done right now. Thanks.
Jonathan, I want to thank you for that comment. It aligns with really with the goals and what we were referring to earlier in the presentation. IHE, we talk a lot about technology, but we are a group that is obsessed with process and making sure that we are recommending best practices that the IHE at its core is about building consensus around those best practices and offering those as a global good through our profiles to support organizations to be able to leverage those standards in a process that they can effectively work into their product and their clients' workflow. And it's part of our goal of this, our upcoming Path to Production series, is to have these kind of conversations that we're having right now, uncovering areas of process barriers, understanding who the actors are in regards to those workflows, and finding solutions, whether it's process, whether it's it's really a combination of process and technology, but finding the right pieces to offer up a best practice for the good of all organizations that are seeking to utilize those best practices. I just want to make sure we're being considerate of your time, and Chris, let us know if when we need to wrap this conversation up. But we've heard some areas of focus in the new year around syndromic surveillance and its impact both on COVID and on future pandemics. Some priorities around finding and fixing delays in interfacility transport, a more sort of a meta issue being knowledge gaps in pre, post, and in hospital environments, and getting the data needed to fill those gaps to where it needs to be when it needs to be sent there. Are there other top line priorities that it's important that we talk about on this call, and that we think about as we map out how to move through 2022 with IHE supporting the efforts of NEMSIS and the wider EMS community? Any other items that are of importance to your organizations, your clients, that we should be aware of and talk through further?
Adam, this is Zeke Peters. I work for Contexture, the new combined HIE between Arizona and Colorado.
Hi, Ezekiel. Thank you for sharing. Love to hear your perspective.
Yeah, I was just going to make an observation here about, I think your approach is logical to ask about the use cases, right? And that it may not, this is just one domain of folks who need to speak to those, but I would suggest a reframe somewhat, which kind of go to Andrea's comments about how this line of work was begun initially, which is that I have definitely used the term use cases a lot previously, but what I'm discovering as we try to do the COVID-19 work is that it's probably better to narrow that down to what decisions are we trying to support, because what I think is happening is we're having a lot of exchange of data for what seem like general conceptions about we ought to put some stuff in a bucket, but in reality we're connecting to legacy registries that don't actually lead to meaningful actions. And so I think the question about barrier removal would be another sort of one about these are very specific kinds of actions or decisions that you could be supporting if you had a particular kind of data or visibility. And I think that's maybe shifting the conversation slightly that way would yield better results in terms of actually having these standards unstick something.
Ezekiel, thank you for that frame. You can't see my mind currently being blown, but I can share verbally that is I always appreciate when the blinders are pointing me in one direction and somebody just turns my head a little bit and says, "Look over here." That's such a wonderful frame to build these conversations around. Thank you for sharing that. Other thoughts from the group? I believe we may have 5 more minutes or so.
If there are maybe questions too that we want to spend this last few minutes of this presentation also going over some questions that you may have had during this presentation, or about some of the or comments, we're also good. I would also recommend we take some questions.
Andrea does have her contact information up here as well. My colleague John and I will share ours in the chat window, and we look forward to connecting back with this group and continuing these conversations, thinking about those decisions that are priority decisions that you and your clients need to make, and how IHE can support those efforts. But again, wanted to thank everybody for their time and appreciate the thoughts shared during today's call.
Yes. You're welcome to ask any questions about this presentation, or maybe just general questions about FHIR, about testing, or none of the above. You are welcome to reach out to any of us with questions or comments.
Awesome. Thank you, Andrea and Adam, for that great presentation, all that information. Thank you. Again, looks like you're putting your contact information into the chat. So anybody who wants to continue this conversation offline here is more than welcome to. Thank you, everyone, for taking the time today to participate in this training. Once again, this presentation is being recorded and will be available on our website and on our YouTube channel shortly. If you want to be notified about events such as these that come up in the future, you are welcome to go to the main NEMSIS website, and in the upper right-hand corner, there is a button to subscribe to our Google group, which is where we make most of the announcements for these types of events and other information that, that is important to our stakeholders. That is a free service. And if you have any questions about that, feel free to get in touch with me about it. Other than that, I hope everyone has a wonderful rest of their day, and we'll talk to you again soon.